Welcome to this final presentation on disorders of the gastrointestinal system. And within this last presentation, I specifically want to review pathologies of the liver. So what I really want to cover in this presentation is firstly talking about the functions of the liver. We'll then talk about the signs and symptoms for patients who have liver disease. And then we'll talk about some specific considerations for the physical therapist in managing patients with liver dysfunction. We'll then review jaundice, the different types of jaundice, hepatitis, the different types of hepatitis. And then we'll talk about end-stage liver disease, specifically cirrhosis, which may warrant the need for a liver transplant. And then we'll talk about the management of patients with liver transplant. So let's start with talking about the functions of the liver. And I like to talk about the functions of the liver because it's important to understand what the liver does to better appreciate what the liver is unable to do under bouts of pathology. So as we know, one of the first major functions of the liver is the excretion of bilirubin. So really, what is bilirubin? Bilirubin is the end product of heme metabolism. So we know our red blood cells, they have a certain life, and after that life, they disintegrate, they break down. And these red blood cells, they're made up of two major types of molecules. They're made up of the heme molecule and the globin molecule. And when the red blood cell disintegrates and breaks down, then the heme component of that red blood cell, when that breaks down, the heme breakdown produces this molecule called bilirubin. And so what the liver does is that it takes this bilirubin from heme metabolism and converts that bilirubin to bile. And the bile, the bilirubin, basically converted to bile, is what gives feces its brown color. The second major function of the liver is that the liver is important in the production of plasma proteins, the production of plasma proteins. And one of the most commonly seen plasma proteins in the human body is albumin. So why do we need these plasma proteins? These plasma proteins are important because these plasma proteins, they are in the blood vessel and they exert an oncotic pressure. They exert an osmotic pressure. And this oncotic or osmotic pressure keeps water in the blood vessel. If you don't have that osmotic pressure or that oncotic pressure, then the water gets out of the blood vessel and moves into different spaces of our body, including the peritoneal space, the interstitial space, the pleural space, etc. So it moves into different spaces. So really, to keep water in our blood vessels, we need these protein molecules. We need albumin, which exerts an oncotic or an osmotic pressure that keeps the water in the blood vessel. If we don't have the proteins, then the water moves out of the blood vessel into different spaces, including the peritoneal space. The liver is also important for the production of clotting factors, specifically clotting factor 8, 9, 10, and 12. But you don't have to really worry about which ones. Just know that the liver is really important for the creation of clotting factors. And so if they don't have enough clotting factors because of liver disease, these patients' bleeding times are going to be altered. The liver is also important for the storage of vitamins, and the only vitamins we can store are the fat-soluble vitamins. And we have really four major types of fat-soluble vitamins, which are vitamin A, vitamin D, vitamin E, and vitamin K. A, D, E, and K are the four major types of fat-soluble vitamins that are stored by the liver. We know that the liver is important for nutrient absorption and metabolism. Of course, glucose is a very important molecule that is metabolized in the liver through the process of glycolysis. We know glycogen is made and stored in the liver. So the storage of glycogen occurs in the liver as well as the muscle. And so if there's liver dysfunction, that may be altered as well. And finally, the liver to some extent helps with filtration of blood. So we know that all blood goes to the liver, and the liver has its own very specific circulation that we call the portal circulation, that we call the hepatic or portal circulation. And because all blood goes through the liver to some degree filters toxins, it filters chemicals, it filters medications that they may be in blood. So certain types of medications, they're often filtered at the level of the liver. And sometimes as they have been filtered at the level of the liver, they damage the parenchyma of the liver. They may damage the tissue of the liver. So that's why patients on certain types of medications need to go for routine liver function tests every twice a year, biannually, or maybe once a year, etc. This is most commonly seen in patients who are on medications to control their cholesterol levels, which are what we call the statin medications. And these statin medications, they tend to damage liver parenchyma as they are being metabolized at the level of the liver. Also, the liver filters alcohol, and sometimes as it filters alcohol, excessive alcohol consumption may damage the liver parenchyma or the liver tissue. So those were a very brief overview of the functions of the liver. Now that we know what the liver does, let's look at the signs and symptoms of patients with liver disease. And one of the first things we see in patients with liver disease is they tend to have very dark urine, dark yellow urine. And that dark yellow urine exists because the bilirubin that needs to be converted to bile is not converted to bile at the level of the liver. The liver is supposed to convert that bilirubin to bile. But if it's not converted to bile, then that bilirubin starts to build up in the liver, and then it spills out of the liver into blood. So that bilirubin is going to spill out of the liver into blood because it's not being converted to bile. And that bilirubin that spills out in the liver is then going to be taken to the kidney through blood. And then it's going to be excreted at the level of the kidney in urine, which causes the urine to become dark yellow. So it's dark yellow in color because of the bilirubin that is spilled out of the liver, that goes to the kidney and is excreted in urine. These patients with liver disease will also have very pale light stool. So it doesn't have that brownish color because that bilirubin is not being converted to bile, and that bilirubin in bile is what gives feces its brown color. If you're not converting that bilirubin to bile, then the feces doesn't have a very dark color. It has a pale brown, pale coloration within stool. The skin becomes yellow. Patients will appear jaundiced. Again, the bilirubin spills into blood because it's not being converted to bile, and that bilirubin gets dislodged in the mucous membranes of the skin. And because it gets dislodged in the mucous membranes of the skin, it turns the skin yellow. It turns the skin this turns the sclera of the eyes, the whitish portion of the eye, yellow. So the sclera of the eyes, the skin turns yellow because of that bilirubin being dislodged into the skin. Now, the normal levels of bilirubin in blood, are about 0.1 to 1.0 milligrams per deciliter. So the normal levels for bilirubin in blood are 0.1 to 1.0 milligrams per deciliter. When patients have increased bilirubin levels in blood, we call that hyperbilirubinemia. Emia means in blood, so there's excess bilirubin in blood, hyperbilirubinemia, and that is when bilirubin levels in blood go greater than 1 milligram per deciliter. We also see pain in the right upper quadrant. The right upper quadrant really is where the liver really is, so they'll have tenderness to palpation and pain in the right upper quadrant of the abdominal cavity. They can refer pain, there's musculoskeletal involvement, and there's usually referred pain to the right shoulder and mid-scapula. So usually when patients have liver disease, we will see referred musculoskeletal pain to the right shoulder and mid-scapula. Now, sometimes we see these spider angiomas, which are branched dilation of superficial capillaries. And we see these spider angiomas, these branched dilation of superficial capillaries, really mostly in the face and in the back. We see this network of superficial capillaries, a network of capillaries in the back and on the face. We also see palmar erythema, which is like a redness that we see on the thenar and hypothenar eminences of the hand. So we see a redness, this hypererythema, this redness color on the thenar eminence and hypothenar eminence of the palm of their hand. And really, the reason why people get these spider angiomas and this palmar erythema is because they're not metabolizing estrogen very well. So estrogen is metabolized at the level of the liver, and if it's not metabolized very well, then they have excessive estrogen. They have something called hyperestrogenism, too much of estrogen, which causes the dilation of the capillaries and the redness that we see in the palm, on the face, and on the back. Additional symptomatologies include hepatic encephalopathy. So the reason why patients develop encephalopathy, which is personality changes, confusion, they get very confused, they can't concentrate, they can't think very well, is because of the inability to metabolize ammonia. So ammonia is a waste product, and when you're not metabolizing that ammonia, then they develop this personality changes. They have confusion. They also develop a tremor. And a positive Babinski and increased tone. So whenever you see a positive Babinski and increased tone, then we know that the brain and spinal cord are involved, or the patient now presents with an upper motor neuron dysfunction. So upper motor neuron issue is because the brain is now involved. So there is brain involvement causing a positive Babinski sign, increased tone, a tremor, as well as personality changes and confusion. The tremor that they have is what we call asterixis. We call it asterixis, A-S-T-E-R-I-X-I-S. That's A-S-T-E-R-I-X-I-S, which are these jerky movements of the wrist and hand when you stabilize the forearm. So you stabilize the forearm, and then you pull back. When they pull back their wrist and hand into extension, then we see jerky movements of their wrist and hand. And again, this is because of the ammonia building up in blood, and that ammonia goes to the brain and basically causes these upper motor neuron issues. We also see portal hypertension. And portal hypertension is really because of increased pressure in the portal vasculature. So there's more pressure in the portal vasculature. There are two veins that cause the portal vein. We have the splenic vein and the mesenteric vein that combine to form the portal vein. And the normal pressures in the portal vasculature, is about 3 to 5 millimeters of mercury. 3 to 5 millimeters of mercury. Now, when somebody has portal hypertension, we see pressures that can go up as high as 25 millimeters of mercury, that cause excessive pressure in the portal vasculature. So when there's high pressure in the portal vasculature, there is increased hydrostatic pressure. Increased pressure in the portal vasculature, which is what we call the hydrostatic pressure that is within that portal vasculature. And that increased hydrostatic pressure leads to what we call ascites or edema, which is these very large bellies or abdominal sizes because of fluid in the peritoneal space. That's what ascites is. Ascites is when you have fluid in the peritoneal space. So the peritoneal space is a virtual space that exists between the visceral and parietal pleura. So every organ is covered with a lining, and we call that lining the visceral pleura. And then we have the entire abdominal cavity encased in a covering that we call the parietal covering. So between the visceral and the parietal linings is a virtual space that we call the peritoneal space. And when fluid starts building in that peritoneal space, that's what we call ascites. Now, the ascites is really because of portal hypertension, because when somebody has portal hypertension, they have increased hydrostatic pressure within the portal vasculature that drives fluid out of the portal vasculature into the peritoneal space, making their bellies look really big. They also may have hypoalbuminemia. When they have hypoalbuminemia, you cannot keep that fluid in the blood vessel. So because you don't have enough plasma proteins, so you have less albumin, you have less plasma proteins. So water cannot stay in the blood vessel. It moves from the blood vessel into the peritoneal space. Let's continue with the special implications for the physical therapist in managing patients with liver dysfunction. So the first thing is important to appreciate any factors that may increase intra-abdominal pressure. So we want to avoid patients from holding their breath, doing what we call a Valsalva maneuver. We don't want them to bear down, straining for a bowel movement, excessive coughing. All of these factors increase intra-abdominal pressure, which in turn may increase portal pressure. So we want to minimize these factors that increase intra-abdominal pressure and any increases in portal hypertension. We also want to give them a Fowler's position, which is a semi-reclined position. So they're kind of in a, not completely supine, but in about 60 degrees upright with their hips and knees flexed. Fowler's position, semi-reclined, hips and knees flexed. And when we put them in a Fowler's position, the advantages of the Fowler's position is that the fluid from the peritoneal, it kind of takes some stress off their hips and knees when it's flexed, because their hamstrings are usually tight, and when their hips and knees are flexed, then you take some tightness off the hamstrings. It helps with their breathing. They can breathe better. It makes them more comfortable. It kind of puts the diaphragm at a slightly better length tension relationship, and when they're semi-reclined, then the fluid from the peritoneal space, the ascites, doesn't move up as much into the lungs, so they can it doesn't compress the thorax as much, so they basically breathe a little better. The disadvantages is if there's a lot of pressure on the sacrum, and because there's a lot of pressure on the sacrum, they can damage their skin around their sacrum, developing sacral pressure ulcers. So we need to make sure that we reposition them every 2 hours and not keep them in the Fowler's position all day just because they like that position. And the other thing is, if the hips and knees are flexed, for a lot of the time they may be at risk for developing hip flexion contractures. So we need to make sure that we change their position frequently. Postural mechanics, they tend, just like someone when they have a large belly, they tend to have a greater exaggeration of their lumbar lordosis. So because they have exaggeration of their lumbar lordosis, that increases their likelihood for back pain. So we need to make sure that that is managed as well. Sometimes, all right, so we talked about that. Now let's talk about rest. They do need rest, so rest is important, but we also need to make sure that they do some activity. And so activity pacing is important. Short bouts more frequently. So if you're doing an exercise session, maybe about 15 minutes or 10 minutes or about 20 minutes, multiple times a day, is better than a 60-minute session one time a day. So we need to make sure that we plan, pace their activities. Interval training, short bouts more frequently is the way to go. We want to plan our schedule with other disciplines. So if they have, 20 minutes of PT, then they don't want to have 20 minutes of OT right after. You need to give them some rest and a break before the next service comes in. We also may want to think about reducing the intensity of exercise and slowly progressing the intensity of exercises. In terms of activity pacing, you may want to start with single joint exercises and then progress them to multiple joint exercises. So having them do multiple joint exercises right away may not be appropriate at the initiation of activity. You can do fewer sets, fewer reps. Sometimes we may want to prescribe an assistive device for a patient to allow them to conserve their energy and make it easier for them to do the activity. We want them to do universal, now known as standard precautions. So we used to call it universal precautions, but now we changed the terminology to standard precautions, which is hand hygiene. We need to wash our hands, of course, use gloves, gowns. And if patients have hepatitis B or hepatitis C, then you need to use more specific precautions, like maybe a gown and a face mask and eye goggles, etc. Laboratory values that are important to check are the platelet level. Sometimes the platelet level is often reduced in these patients. The normal platelet level is about 150,000 to 450,000. But in patients, if their platelet levels are less than 20,000, then we want to not really do resistance exercises with these patients. You want to avoid resistance exercises for patients with a platelet level less than 20,000 because they're at increased risk for bleeding and internal bruising. The hematocrit levels also sometimes may be reduced, so that may reduce the oxygen carrying capacity. So that's an important thing to think about in these patients. So let's move into jaundice. Jaundice, also known as icterus, that is ICTERUS, jaundice, also known as icterus, is really not a disease. It is not a disease, but rather a symptom of a disease. So really, when people are jaundiced, it's not really a disease, but they present with jaundice. They present with jaundice when they have liver disease. So when patients have liver disease, they present in a state of jaundice. And jaundice is characterized by the yellow discoloration of the skin, the mucous membranes, the sclera of the eyes. And that's really because of that bilirubin being dislodged in these different areas of the body. So the risk factors for these patients, they may be a risk factor may be contact with the jaundiced person, especially if that person is jaundiced from hepatitis B or hepatitis C, then that could increase your risk for developing jaundice. Splenectomy, removal of the spleen. The liver and the spleen work very close together, so when they remove the spleen, that increases your risk for developing jaundice. A cholecystectomy, which is the removal of the gallbladder. A history of hepatitis. Chronic alcohol consumption, because alcohol may be toxic to the liver. Sometimes newborns present with jaundice because of an immature liver. When they have an immature liver, the newborn can present in a state of jaundice. And also eating raw shellfish. Eating raw shellfish can be toxic to the liver. So when we think about jaundice or icterus, we can classify it as having three major types of jaundice. We have a prehepatic jaundice, a hepatic jaundice, and a post-hepatic jaundice. So prehepatic means the disorder or the dysfunction is before the level of the liver. Hepatic means the dysfunction is within the liver. And post-hepatic is the dysfunction is beyond the level of the liver, is after the liver. So there's some problem after the liver. So let's talk about each of these a little more in the next 3 slides. So, so we already talked about the risk factors, so I don't have to go over that again. But in terms of prehepatic jaundice, so right now we see there is a lot of bilirubin increases in the absence of liver disease. So now bilirubin is increasing, but it's not because of liver disease. It's because of too much of breakdown of red blood cells. So there's over-release from the hemolysis of red blood cells. So there's so much of red blood cell breakdown that the liver cannot handle all that RBC breakdown. It cannot handle all that heme that is being broken down. So there's so much of bilirubin being produced that the liver cannot convert all that bilirubin to bile. This is usually from hemolytic blood transfusion. So you give somebody the wrong blood type, and it breaks down a whole bunch of red blood cells beyond which the liver can handle. Hemolytic anemia, same thing. An exaggeration of the breakdown of red blood cells. Severe burns, sickle cell disease, all of these can break down an excessive amount of red blood cells that increases bilirubin before it really gets to the liver. So the problem is really not at the level of the liver. So these patients, because they're breaking down a lot of red blood cells, they're very weak, they're fatigued. They may have abdominal or back pain, especially if they're bleeding posteriorly into the posterior aspect of the abdominal cavity. Their stool looks normal, their urine looks normal because they don't have any liver disease. They don't have any liver disease, so the stool and the urine look normal. So that's really what we see in people with prehepatic jaundice. In people with hepatic jaundice, now the problem is within the level of the liver. So now the liver there's an alteration in the pathology of the liver. That's what we see as true jaundice, is when there's liver pathology. And the liver pathology can be because of hepatitis, it can be because of cirrhosis, it can be because of cancer that metastasizes to the liver, which now causes the person to become jaundiced. It can be prolonged use of medications that destroys the liver parenchyma. All of these can cause what we call hepatic jaundice. And because the person now has liver disease, they will have malaise, they may have anorexia, they will have dark urine, right upper quadrant pain where the liver is. They may have a low-grade fever if they have an infection, palmar erythema. All of the signs and symptoms that we see with liver dysfunction will be present in addition to the jaundice, because the problem is now within the level of the liver. Let's move to the third type of jaundice, which we call post-hepatic jaundice, which is what we call obstructive jaundice. Now, this is where we see impaired bilirubin transport out of the liver due to bile duct obstruction. So now the liver is taking that bilirubin, converting it to bile, but there is no way for that bile to get out of the liver, which bile is stored in the gallbladder, and then it goes to the intestines, and it is excreted in our feces. But when you have post-hepatic jaundice, obstructive jaundice, then the impaired bilirubin transport out of the liver is compromised. These patients have bile duct strictures. They have bile duct strictures, gallstones, pancreatic cancer, pancreatitis, all of which obstruct bile flow out of the liver. These patients have weight loss with carcinoma, because especially if they have pancreatic cancer, then they may have some weight loss. They have right upper quadrant pain, dark urine, light colored stool. Dark urine, light colored stool. Again, because if you're not getting rid of that bile, then the bilirubin starts to really leak out of the liver, and your urine turns dark, and your stool may turn light, because you're not really getting that bile to where it needs to get to. So those were the major types of jaundice. In terms of treatment, sometimes they do surgery to fix the causative factor. So if the jaundice is caused by something that warrants surgery, then surgery is the treatment option. Otherwise, we just give them rest and supportive measures. We treat their pain. We provide them with rest. And the prognosis really depends on the underlying cause. If we can fix the underlying cause, then the prognosis is better. If we cannot fix the underlying cause, then the treatment is definitely more guarded and compromised. Once you treat the underlying factors, the jaundice fades away slowly. So let's move into hepatitis now. And hepatitis is inflammation of the liver. And the inflammation of the liver, that's what itis is. Inflammation of the liver can be because of a viral source, toxic sources, autoimmune hepatitis, or alcohol hepatitis. So viral hepatitis can be categorized alphabetically based on the type of virus involved. So you have different letters designated the different type of virus. Hepatitis A, hepatitis B, hepatitis C, etc. All because of the different types of viruses that may affect the liver. You also have cytomegalovirus, Epstein-Barr virus, herpes simplex virus, measles virus, all of which can affect the liver. So now let's move into a discussion of each of these. So hepatitis A is really affects more children and young adults, and it is spread in the environment due to poor sanitation, overcrowding, daycare centers, schools, and the transmission is by fecal oral route. So you go to the bathroom, you don't wash your hands, and then it's infected food handlers touch food, and then it goes from one person to the other. You diagnose it based on a blood test. And prevention is the key. Personal hygiene, sanitation, and even doing a vaccine is important. In terms of hepatitis B, this is called serum hepatitis, is the most common cause of chronic hepatitis. So here, the transmission is by blood and body fluids, body tissues, through blood transfusion, oral sexual contact, contaminated needles. So you take a blood test, you have a contaminated needle, or you get contaminated blood, or you're in contact with contaminated blood, you may develop hepatitis B. There is a vaccine. I think most clinical affiliations now require you to have the hepatitis B vaccine because for healthcare practitioners, for healthcare workers, they are at highest risk of developing hepatitis B because we're frequently in contact with needles and blood and body fluids, and so prevention through use of the vaccine is very important for these individuals, for us to prevent ourselves from getting hepatitis B. Hepatitis C accounts for approximately 60 to 70% of all chronic hepatitis patients, and the transmission is parental. Parental means it's via blood. Parental means through blood. That's what the word parental means. And so blood transfusions are the most common. And so we need to really screen blood and avoid contact with blood to the best of our ability. Toxic hepatitis is inflammation of the liver secondary to exposure to certain toxins, certain chemicals or drugs like Tylenol, carbon tetrachloride, organic pesticides, alcohol. Oral contraceptives too may impair liver function, causing jaundice without causing necrosis. Removal of the causative agent is important. Gastric emptying, we put a nasogastric tube and empty the abdominal cavity so it takes stress from the GI tract and the liver, and providing them with adequate rest is also important. Activity, pacing, energy conservation is important. Autoimmune is idiopathic chronic hepatitis, and the idiopathic chronic hepatitis is characterized by presence of autoantibodies, high levels of serum immunoglobulins. So basically, there are antibodies, immunoglobulins that invade the liver parenchyma. And because they invade and destroy the liver parenchyma, it leads to liver dysfunction, and the signs and symptoms are similar to liver dysfunction. So here, autoimmune is the presence of antibodies, immunoglobulins that really destroy and invade liver tissue. Alcoholic hepatitis, the cause, of course, is excessive alcohol consumption. And this may be acute or chronic. So sometimes if you have an excessive amount of alcohol over a short period of time, it may lead to an acute hepatitis. Or if there is excessive alcohol consumption over prolonged periods of time, like 12 to 24 beers a day, every day, for several months or years, can really damage the liver, as we know. Symptoms, they have anorexia, they have nausea, they have vomiting, jaundice, abdominal pain. Of course, excessive chronic alcohol consumption can lead to end-stage liver disease, which is what we call cirrhosis. And the prognosis, of course, for alcoholic hepatitis is based on the termination of alcohol. If patients can stop taking the alcohol, then they feel a lot better. If they don't, their prognosis is good. If they are not able to stop, alcohol consumption, then the prognosis is definitely more guarded. So now let's talk about cirrhosis. Cirrhosis is end-stage liver disease. And end-stage liver disease resulting from a variety of chronic inflammatory, toxic, metabolic, or congestive damage. So it's really a group of end-stage liver diseases because of end-stage damage to the liver tissue. Etiological factors may be because of alcohol. It may be from drugs like certain medications that are taken over a long period of time. Or it also could be caused from PBC, which is primary biliary cirrhosis. Primary biliary cirrhosis. And in primary biliary cirrhosis, this is where we see chronic progressive liver disease due to inflammatory destruction of the common bile duct. There is inflammatory destruction of the common bile duct. So the bile duct allows bile to go from the liver to the gallbladder. And when there's inflammatory destruction of the bile duct, then the bile backs up into the liver, causing destruction of the liver parenchyma. So with chronic, when there's inflammatory destruction of the bile duct, then bile is basically not getting out of the liver, so that bile starts to accumulate in the liver and it destroys the liver parenchyma. So that's what we see with PBC, or primary biliary cirrhosis. So here's what you can see in a normal liver. The normal healthy liver has pretty nice lobular architecture, pretty nice normal lobular architecture. But when somebody has cirrhosis, they have this fibrous connective tissue, they have nodules, the liver kind of shrinks, there's distortion of the vascular bed in the liver. Sometimes they may have bleeding varices because of that portal hypertension. So the liver changes in size and appearance. It loses its normal lobular architecture. It looks very fibrous, nodular. It shrinks, and there's obstruction of biliary channels, etc. How do we diagnose a patient as having liver disease? So we look at as having cirrhosis. How we diagnose cirrhosis? So we look at liver function tests, which are called LFTs. LFTs are liver function tests, LFTs. And elevated liver function tests include elevated liver serum enzymes like alanine transferase, ALT. ALT is alanine transaminase. So if you remember from physiology, there's a process called the transamination process. And the transamination process is the process of making new amino acids by transferring the amine group from one molecule to another. So that's what we call a transamination process. And then we have this transamination process occurs in the liver. And we use certain enzymes. We use ALT, alanine transaminase, AST, aspartame transaminase. And so when the liver is damaged, then the liver cannot do anything with these enzymes. So these enzymes start to spill into blood, and they start elevating in blood. So the liver is unable to use these enzymes to really allow for the process of transamination. And so they spill into blood and they start elevating in blood. So elevation of the ALT, elevation of the AST, elevation of the liver function test enzymes will be seen in patients who have liver dysfunction, end-stage liver disease, or cirrhosis. We're also going to see hypoalbuminemia. They're going to have low levels of albumin in their blood because the liver is not producing albumin. They're going to have altered clotting factors. So their prothrombin times, PT, or their partial thromboplastin time, PTT, will be increased. Their clotting times will increase because they don't have those clotting factors that are made by the liver. There is hyperbilirubinemia. The normal levels of bilirubin are 0.1 to 1.0. And now the bilirubin levels in blood will be greater than 1 milligram per deciliter. So that's really how we diagnose patients with cirrhosis. In terms of treatment, we need to remove the causative agent. We need to make sure that they don't drink their alcohol if that's what's causing it. If there's PBC, they may have to surgically fix the biliary duct to prevent further damage of the liver parenchyma. In terms of treatment also, we really need to give them a proper diet. So nutrition is a key because they're really anorexic. They're not having good vitamins, minerals. They don't get enough protein in their diet. So usually a nutritionist needs to be involved in the care. A nutritionist or a dietitian needs to be involved in the care of these patients because they need to really make sure that the patient is getting adequate amounts of protein, adequate amounts of minerals, vitamins, etc. Now, sometimes they manage symptoms in a different way. So if somebody has ascites, large amounts of fluid in the peritoneal space, they do a condition called a paracentesis, P-A-R-A-C-E-N-T-E-S-I-S, a paracentesis, which is a needle aspiration of fluid from the peritoneal space. So they place a needle into the peritoneal space, and that needle siphons out fluid, and they collect that fluid into jars. They can collect liters of fluid from the peritoneal space. So once you drain out that fluid, of course, their bellies become smaller, they can breathe better, they can tolerate exercise better, much better to see them after the paracentesis procedure. Now, sometimes when they have a lot of ammonia in their blood that's going into their brain, we give them a little medication called lactulose. That's Lactulose, lactulose. And lactulose is like a little cocktail. It's like a little shot glass, and it's like a little cocktail, but it's not really a cocktail because it tastes extremely nasty. Not that I've tasted it, but I've seen patients have it, and it tastes extremely nasty. But it really helps remove the ammonia from their blood. It helps reduce the symptoms of encephalopathy. So what happens is when they're given lactulose, they have a lot of diarrhea. They have really bad diarrhea. So they tend to poop out a lot. And so sometimes when they poop out a lot, they can't move a lot because they've got these large levels of ascites. It makes them difficult to move because of that big belly. Plus, they're very tired and fatigued. So because they can't move very well to get to the bathroom frequently, they put in a fecal management system. They put in a rectal tube or fecal management system because they have really bad diarrhea after lactulose. So they give them lactulose, they put in a rectal tube, and they wash out that ammonia that's collecting in the blood and in the body. Now, sometimes, if people are excessive alcoholics, it's important to understand that, they need a certain amount. The brain starts getting used to a certain amount of alcohol. So the synapses in the brain occur because of a certain amount of alcohol the patient is used to, because they're drinking half a bottle of vodka a day, or 6 martinis a day, or 24 beers a day, and they're used to a certain amount of alcohol to allow for the synapses in the brain. Now, they get admitted into the hospital and you completely take away alcohol overnight, then the brain cannot handle that. The brain cannot handle all those synapses that need to occur because of that alcohol being present. So they go into a state called delirium toxicity, which we call DTs. It's abbreviated as DTs in the hospital. They go into a state of delirium toxicity where they really become delirious. They become kind of crazy. They become extremely confused and delirious because they don't have the alcohol to allow for those synapses in the brain to exist. So sometimes these patients, they start, punching nurses, and they start trying to run out of the hospital, and they just try to get out of bed when they cannot get out of bed. So sometimes they may need to be put on restraints. And so we really don't like restraining patients, but sometimes they need to be put in restraints for the safety of the medical staff. Now, and if somebody is going into a state of delirium toxicity, it is not uncommon. It is not uncommon to see physicians write an order for a certain amount of alcohol to be given to patients every day in the hospital. So they may order for like 2 scotches a day, or, 2 beers or 4 beers or whatever, just a small amount of alcohol as they wean the patient, and as they treat the patient hard. So initially when they come into the hospital, if you completely stop alcohol, they go into delirium toxicity. So giving them a small amount of alcohol is not uncommon in these patients. So now let's talk about patients. So how do we diagnose, before we go into liver transplant, I'll move into the final issue of treatment for patients with liver cirrhosis, and that is liver transplants. And liver transplants, there are different types of liver transplants. The first is what we call an orthotopic liver transplant. And now an orthotopic is when you take out the diseased liver, you take out the damaged liver, and you put in a cadaveric liver, a liver from a cadaver, a person who has recently expired, and you put that liver from that expired person that is matched with the recipient in the exact same position as the old liver. So you take out the old liver and you place in the new liver in the exact position, and that new liver is usually from a cadaver. That's what we call an orthotopic liver transplant, which is very common, which is the most common type of liver transplant. We can also do an living adult donor liver transplant, where we take out the entire cirrhotic liver. We find a matched living donor now. You find a matched living donor, usually an immediate family member, and then they cut out a small piece of liver from the living adult donor, and you place that small piece of liver into the recipient, and because the liver can regenerate, both the livers regrow within the donor and the recipient. So you cut out a small piece of liver from the matched living adult donor, and you place that small piece into the recipient, and because the liver can regenerate, the livers continue to grow in both the donor and the recipient. We also have something called a split liver transplant. And in a split liver transplant, you take a cadaveric liver, you take a liver from a cadaver, and you cut it into 2 parts. You cut it into a major lobe and a minor lobe. The major lobe is given usually to an adult, and the minor lobe may be given to a child who has a dysfunctional liver. So they take the liver and they break it up into 2 parts from a cadaver. One part they give to a matched adult recipient, and another they give to a matched child recipient. The final liver transplant we can see is something called a domino liver transplant. And domino liver transplants is only used for patients who have something called FAP. FAP, which stands for familial amyloidotic polyneuropathy. Familial, FAMILIAL, amyloidotic, AMYLOIDOTIC, amyloidotic polyneuropathy. So familial amyloidotic polyneuropathy is really an inherited disorder. It's really an inherited, means you're born with some kind of genetic issue. And they're born with this genetic issue where there is a metabolic defect in the liver. It's a metabolic defect in the liver where the liver is structurally normal and functional. So the liver is completely fine. It's structurally normal and it's functioning normally. But what the problem is that these individuals are synthesizing an abnormal protein called transthyretin. So transthyretin is an abnormal protein that forms amyloid plaques, amyloid fibrils, that affects the peripheral nerves and the autonomic nervous system. So in FAP, the liver is completely normal. It's functioning normal. It's doing whatever it needs to do. It's working fine. The only problem with the liver is that it is creating this abnormal protein called transthyretin. And when you produce transthyretin, it produces these amyloid plaques, these amyloid fibrils that alter the peripheral nervous system, the autonomic nervous system, and the peripheral nervous system. And in this, and in patients with FAP, even though it's a inherited disorder, they don't often present with this transthyretin increases or alterations in their peripheral nervous system and autonomic nervous system till they're about 15 years of age or older. So why do these patients benefit from a domino transplant? So in a domino transplant, there are 3 people involved. So we have the donor, we have the patient with FAP, and we have a patient on a transplant list. So we have a donor, we have a patient with FAP, and a patient on a transplant list. So the donor gives their liver to the patient with FAP. So when the donor gives their liver to the patient with FAP, then the gene that is in the patient with FAP will no longer work on the new liver. So there's a donor that gives their liver to the patient with FAP. And when they give their liver to the patient with FAP, the inherited gene that the patient with FAP had does not work because now they have a new liver and the gene does not work on that new liver. It only works on the liver that they were born with, not on this new liver. So the patient with FAP does good. And then the patient with FAP, they take their liver, because their liver is really working great, and they give it to the patient on the transplant list. So there's a domino effect. One person gives it to the next person gives it to the next person. The donor gives their liver to the patient with the FAP, and the FAP gives their good liver to the patient on the transplant list. And the patient on the transplant list, as you know, does not have any genetic issues. They don't have the gene that is making transthyretin. So that liver that goes from the patient with FAP to the patient on the transplant list does not have any issues with making transthyretin because they don't have the abnormal gene. So that's how domino liver transplants benefit people who need a liver as well as patients who have FAP, familial amyloidotic polyneuropathy. So finally, let's talk about PT implications in patients with liver transplant. So after liver transplant, this is a big surgery, right? This is a big surgery. They come out of surgery with 2 types of drains. One is called a Jackson-Pratt drain, which are little like suction drains that come out of the belly. And they also have something called a T-tube. So Jackson-Pratt drains, they're draining secretions from the liver and from the abdominal cavity. And usually the drainage in those Jackson-Pratt drains should look brownish red. If it starts looking pale or whitish, we need to call the doctor or the nurse and inform them about that, because that may be a sign of rejection. The T-tube is the tube that drains bile. And it is very important after surgery that the T-tube, that the amount of bile is measured every day in the T-tube. It drains bile. And the bile should be dark green in color, like this presentation. So, like this PowerPoint slide. And if it's dark green in color, then we know that the liver is functioning normally. If the amount of bile reduces in quantity, or the color changes from that green to a brownish red color, then that may be that the liver is going into rejection. Other signs of rejection include a drop in the bile production, changes in the color of bile, right upper quadrant pain, or like they have jaundice. They're going to present with jaundice. The liver function tests will increase. The AST, ALT, lactate dehydrogenase would also increase. That's another type of liver enzyme, lactate dehydrogenase. The clotting times will increase, again, because they're not producing the clotting factors, because their liver is being rejected. Their platelet levels will go down, again, because the liver is being rejected. Very important to mobilize these patients, give them a lot of rest, light exercise. And right after the surgery, very important to do deep breathing and coughing, because if we don't do deep breathing and coughing with these patients, they're at a high risk of developing a pneumonia. We need to look at the T-tube each day to make sure that they're not going into rejection. And as a physical therapist, we need to work on functional mobility and exercises with these patients. Don't do any sit-ups because it hurts their abdominal incision, and give them a lot of pacing and activity and energy conservation techniques for these patients. So in summary, we have discussed the functions of the liver. We talked about the different signs and symptoms of patients with liver disease. We talked about the differences between jaundice and hepatitis, the different types of jaundice, the different types of hepatitis. We talked about cirrhosis. How do we diagnose cirrhosis? What causes cirrhosis? And we ended with the management of patients with liver diseases, as well as the physical therapy implications, especially after someone has had a liver transplant. Thank you, and this ends all of the content on the disorders of the gastrointestinal system.